Very happy to be with all of you. I'm going to be very short. My task today is to describe the use of intraoperative radiotherapy electrons in rectal cancer disease, and I will make two blocks, one on primary locally advanced disease, which has a management that is rather standard, but also evolving with time, and also in recurrent disease, which is an indication that has given a lot of light on the use of intraoperative radiotherapy in oligorecurrent disease in general. You can see that NCCN mentions the use of intraoperative radiotherapy in rectal cancer. And here you can see that in the ESTRO IORT task force effort that Professor Portman has described, rectal locally advanced and rectal oligorecurrent disease is almost half of the numbers of patients that we have reviewed in the literature. So the data is solid and is very abundant on one side, on the other side is mature. The first pool analysis on locally advanced rectal cancer was made by 4 academic institutions in Europe. We put together more than 600 patients. We look at different prognostic features. We created an index, and we were able to show that rectal cancer is an heterogeneous disease with different prognosis depending on the aggressiveness in the lymph node involvement, in the size of the disease, in the type of surgery, and so on. But intraoperative radiotherapy always helped in all these heterogeneous status, promoting high local control rates. Then we have excellent data on T4's rectal cancer. We are lucky to get the collected data by MD Anderson and Katarina Hospital in Holland. They put together more than 400 patients treated in a very long period of time, and they were able to show that in T4 rectal cancer patient, the local recurrence rate, if there was an intraoperative electron component, was 16% with very nice long-term survival rates. In T4s, was important to have a good enough resection margin in terms of negativity for involvement, but I tend to look at these slides the other way. Even with positive margins, you have a high rate of local control if you add an intraoperative electron beam boost on the total strategy. In Gregorio Marañón in Madrid, in more than 15 years, we were able to treat prospectively patients with an intraoperative boost after pre-op chemoradiation, locally advanced disease, and we were able to see with this type of approach 335 patients analyzed, only 3 in-field recurrences. This includes T4 patients, this includes radio-resistant nodal disease. So all the features that are you can see in heterogeneous rectal cancer, but the local recurrence rate in field is extremely low, almost anecdotal. You can include intraoperative radiotherapy in the advances of surgery. We were able to show in Gregorio Marañón as well that we were able to adapt technically the developments on laparoscopic surgery to the use of an intraoperative boost in the high-risk area in the presacral region. And looking at that, we were able to see that there was no compromise at all in terms of local control or survival by the use of intraoperative boost guided by laparoscopic surgery or guided by open surgery as we did classically in the last decades. This is a summary of the pending manuscript on primary locally advanced disease, rectal cancer from the ESTRO-ACROP task force. It puts together almost 3,000 patients, 21 references, most of them, all of them treated with electrons, a minority treated with radiotherapy, and the overall survival rate is improving because systemic therapy is improving little by little through the decades. And there you have the table of recommendations. To make it short, we include patients with locally advanced disease, meaning by that either a locally advanced T, T3, T4, or any T with N positives in the staging procedures. We have very good data in terms of systematic reviews. Here you have 3,000 patients reviews with primary locally advanced disease and with recurrent disease. And to make short the message, there is an improvement in local control when you use intraoperative radiotherapy compared than in the same institution not using intraoperative radiotherapy component. It has a tendency in survival and in disease-free survival, and there is no difference. The use of intraoperative radiotherapy has not shown any toxicity addition to the regular type of approach without it. I changed the page and the chapter, and this is recurrent rectal cancer. I just want to mention and to recognize the tremendous work done at Mayo Clinic. They were the first in putting together a very large group of patients, more than 600 patients with rectal or colon cancer recurrent. All of them are recurrent. Half of them are recurrent to previous surgery and radiation therapy. And they were the first to show two important things. One, long-term survivors, very long-term survivors at 10 years and at 5 years, almost 1 out of 3, and also a compensation effect of the intraoperative electron boost in the resection status. This was for the first time that a large group of patients, a cohort, was able to compare local control, always with intraoperative radiotherapy, positive margin against negative margins, similar type of local recurrence. This is again a great effort that has been published recently by Mayo Clinic and Caterina Hospital, and they put together more than 500 recurrent rectal cancer patients. They were able to see, they consolidated the information that there are local, very relatively high, not to say very high, rate of patients surviving long term. And another point they make very original, very unique, is that in those patients that were recurrent to previous radiotherapy with new high precision radiotherapy techniques, IORT and BMAT, it's possible to add some component of re-irradiation external that together with the resection and the intraoperative boost are able to improve further local control and survival in this oligorecurrent group. This is also a summary table of the indications and recommendations from the ESTRO-ACROP task force. This paper is being under revision, is very advanced and will be available very soon. And we recommend an intraoperative boost in potentially resectable, even in patients with developing surgery and also in oligometastatic disease. I'll show you a table to call the attention and to provoke especially my surgical colleagues. This is a great table. You look at recurrent patients reported, quite many. I mean, it's not a minor group of a cohort of patients. And we look at the results by R status. R status, they all receive resection, they all receive intraoperative boost, and the majority receive external beam radiation therapy as well. Yes, there is a difference in overall survival looking at the R status. But once again, I want to look at this data in the opposite way. First, alive patients is 1 out of 2 in recurrent disease. And even if you have a positive margin, you have 1 out of 5 alive long-term after intraoperative radiation boost plus surgery plus external beam radiotherapy. And this is my last, will be the next intervention. I will be more than happy to answer questions, and I am, once again, I am very honored to be with you today and to share with you all this data.